Thank you, and thank you very much for attending HRSA's second Risk Management Audio Conference of 2012, entitled A Measure of Quality, Implementing a QI/QA Program. Today's presentation is the seventh in a series of risk management audio conferences designed to assist you in developing an effective, robust clinical risk management program in your health center or free clinic. The HRSA Bureau of Primary Healthcare is committed to supporting efforts to deliver quality healthcare to patients and is partnered with Abt Associates and ECRI Institute to provide this information. On slide 2, you'll see information about ECRI Institute, an independent nonprofit applied research institute where over the past 4 decades we've helped thousands of healthcare organizations across the nation develop patient safety, healthcare quality, and risk management programs to improve patient care. With your audio conference registration confirmation, you received an email link to the slide handouts. We hope you've had the opportunity to print or download the slides. Throughout the audio conference, we'll refer to slide or page numbers in the handouts so you can follow along. This is a continuation of our Brown Bag Lunch audio conferences, all of which are archived on the Clinical Risk Management website if you missed them live. We will have a question and answer session at the conclusion of today's program. However, keep in mind that this audio conference is not the appropriate place to discuss detailed, case-specific aspects of unresolved claims or litigation. Likewise, risk management information provided in this audio conference is not to be considered legal advice. And as with any information provided by ECRI Institute, it's intended as guidance to be used consistent with the internal needs of your organization. This information is not to be viewed as required by ECRI Institute or HRSA. Any detailed, fact-specific health center issues should be addressed to the FTCA helpline, and all questions regarding pending legal cases should be directed to your own organization's private attorneys. I'm now going to turn the program over to Barbara Rebold. Barbara is currently the Director of Risk Management and Healthcare Quality Consulting and Insight Patient Safety Surveys here at ECRI Institute, as well as Director of Operations for the ECRI Institute Patient Safety Organization. Prior to her time here at ECRI, she was the Vice President of Quality Management for Health Partners of Philadelphia, where she was responsible for providing quality improvement leadership to the Department of Medical Affairs and the company overall, including strategic planning, HEDIS, and the National Committee for Quality Assurance Accreditation. She also served as Vice President of Clinical Services and Director of Disease Management and Special Needs and Case Management at Health Partners. Barb has 30 years experience in healthcare and over 20 years experience in all areas of quality management, including utilization management, disease management, patient safety, service improvement, and medical management. She is a nurse with clinical experience as a nurse manager for a community hospital critical care unit, and she serves on the board of directors of the Southeastern Pennsylvania Association for Healthcare Quality and is also a member of the Healthcare Reform Task Force of the National Association for Healthcare Quality. Also on the line today with us is Chris Callahan. Chris is a registered nurse with a master's degree in business administration and has worked with ECRI Institute for 10 years. Chris has over 20 years experience in health center daily operations for both primary care and specialty providers. Chris's past work experience includes as the Assistant Director of Operations in a federally qualified health center in the New England area and the Director of Ambulatory Nursing for a large managed care organization in Southern California, serving 100,000 members in 17 health centers. More recently, Chris works performing clinic assessments at both clinics and health centers where she targets areas where staff can improve operational efficiency, clinical, and risk management issues at the frontline level. And with that, I will turn the program over to Barb.
Thank you, Paul. Welcome, everyone. On slide 3 is listed the learning objectives for today's presentation. This is an interactive presentation, and we'll be asking polling questions throughout the course of the presentation for your input. On slide 4, we see definitions of quality improvement and high-quality care. When developing a quality improvement program, health centers and free clinics should first define quality. Various definitions of quality exist, and health centers should refine their own definitions of quality based on the needs and characteristics of their organization. Once quality is defined, robust quality improvement programs intended to improve patient care and patient satisfaction, maintain staff safety and satisfaction, and improve the overall efficiency and effectiveness of the organization can be developed and sustained. On slide 5, you may be thinking, is there a difference between quality improvement and risk management? As you can see in the figure on this slide, there are some overlapping functions, such as analysis of adverse and sentinel events and trends, root cause analysis, proactive risk assessments, handling patient complaints, and the other functions listed in the middle column on the slide. Both quality improvement and risk management are important for managing risk and improving patient safety. However, there are also areas that make quality improvement distinct from risk management. In general, risk management supports quality improvement. Quality improvement is focused on establishing and measuring quality and performance improvement, analyzing results related to these measures, comparing these results to benchmarks, and developing improvement projects or corrective actions to address any areas needing improvement. Although risk management may also measure and analyze results for areas of high risk and patient safety. Areas such as patient satisfaction, peer review, and provider performance and competency typically fall more within the realm of quality improvement. Quality improvement involves all clinical and administrative departments or areas in the health center. A full-page version of this slide is available at the end of the handout you received by email. We're on slide 6 now. Some important reasons for focusing on quality improvement and developing comprehensive quality improvement programs are listed on slide 6. Several studies highlight inconsistent quality of care provided in ambulatory care settings. For example, a 2003 study by the RAND Corporation noted that for 30 clinical conditions, evidence-based care was provided by healthcare providers in various settings just 55% of the time. In another study conducted by the RAND Corporation in 2007 that focused on care provided to children, provider adherence to quality indicators occurred just 47% of the time. Having an organization-wide commitment to quality improvement principles can lead to significant improvements in patient care and better outcomes for patients. Indeed, studies have found improved quality care outcomes for conditions for which organizations establish performance measures and monitor that performance. The availability of national quality improvement initiatives such as Medicare value-based purchasing, managed care pay-for-performance programs, mandatory reporting programs, and certifications of patient-centered medical homes can be another incentive for health centers and providers to improve quality. Finally, having a quality improvement program and plan is a required element for Section 330 funded health centers and free clinics. And health centers that are applying for FTCA deeming status must verify that they have a quality improvement plan in place. On slide 7, pay-for-performance programs reward high-quality care by linking reimbursement to patient outcomes or the use of best practices. For example, a provider may receive a financial bonus for meeting certain performance guidelines, such as ensuring that patients with diabetes receive recommended blood tests. Some pay-for-performance programs also provide incentives to organizations that adopt health information technology, or HIT, as it's commonly spoken about, and use it to improve care. While more detailed information on pay-for-performance programs is beyond the scope of this presentation, some recommendations for providers who are interested in participating in any pay-for-performance program are that you should know the performance measures that are used, understand how the program collects data, understand how the plan establishes performance targets, and recognize how the plan will reward providers for meeting or exceeding targets. If you're interested in more information on pay-for-performance programs, patient-centered medical home models, or other national quality improvement initiatives, you should refer to the reference slides at the end of this presentation for relevant sources, as well as the 2 resources available on the Clinical Risk Management website that are listed on this slide. On slide 8 are key steps in developing a QI/QA program. While there are plenty of important reasons for having a QA program, developing a program that functions effectively in your organization is crucial. We're going to talk in more detail on each of these steps throughout the course of this presentation. First, we'll discuss setting up a Quality Improvement Quality Assurance Committee on Slide 9. This slide covers the structure and purpose of the Quality Improvement Committee. The purpose of the QI Committee is to oversee the QI plan and develop and monitor QI/QA activities throughout the health center. The committee should designate a healthcare professional as chair to be responsible for leadership of quality improvement activities, and this person will lead the committee meetings. All departments and levels of staff should be represented on the committee in order to gain various perspectives from all stakeholders. Many quality committees include permanent members and rotating members who, for example, serve 1 to 2 year terms to keep a fresh perspective. However, when you're organizing the committee, you'll want to make sure you don't have a situation where the majority of the members rotate out at the same time, or where you have too many members for the committee to be effective. Smaller health centers may only have one quality improvement committee, while larger organizations with multiple sites may have a corporate quality improvement committee as well as smaller subcommittees at each site. For organizations that have multiple quality improvement committees, it is recommended that the corporate or primary committee be responsible for coordinating the efforts of all subcommittees, collecting data from each site or department, and communicating all efforts and results to the governing board as well as to all relevant individuals in the organization. Moving to slide 10, the committee should plan to meet regularly on a monthly basis as recommended. Agendas for QI committee meetings may include the items listed on this slide. The agenda and meeting schedule should be developed based on the Quality Improvement Plan. The Quality Improvement Committee is responsible for developing, revising, and implementing quality improvement plans with input from other staff as necessary, and the committee may want to designate one meeting per year to take a close look at the plan and propose revisions. For instance, if you have a plan and you have multiple items, you can say this item is going to be discussed at this meeting and this item at the next meeting. You don't have to discuss all of the items at every meeting. On slide 11, a sample agenda template appears. The chair or facilitator of the meeting should prepare the agenda and send to committee members ahead of time. You should budget time for each agenda item you'll discuss and try not to run over time. You can always solicit additional comments from team members after the meeting and then discuss these comments at the next meeting. If you find you're consistently running out of time when discussing agenda items, you may have too much on your agenda and you may want to prioritize so you have enough time for meaningful discussion of each item. The sample template on this slide and samples on the next 3 slides are available at the end of the handouts you received by email. On slide 12 is another option for a sample template for an agenda. When using any template, make sure you adapt them to your health center and the needs of your Quality Improvement Committee. Slide 13. Make sure your Quality Improvement Committee sufficiently documents what was discussed during meetings and keeps these minutes on file. Make sure your minutes include all necessary information and detail and are clearly labeled with consistent titles. Plan the meeting date and time for your next meeting and document the date and time in the minutes. Besides being important for reference and ongoing management of the committee, health centers completing FTCA deeming applications will need to submit their minutes to HRSA as part of the application. A sample template for meeting minutes appears on this slide. And on slide 14, another option for minutes is available. The discussion section in this template would include any findings, conclusions, or recommendations related to each agenda item. Each agenda item would also include actions taken or planned, the person responsible, and the date findings are due back to the committee. Again, when using any template, it's important that you adapt them to the needs of your health center and take the steps to implement them as part of your overall processes and procedures. These templates for agendas and minutes will be posted on the Equity Institute website as part of an upcoming quality improvement toolkit. So you'll want to look for that over the coming months. And now I'll turn the program over to Paul for our first polling question.
Thanks, Barb. And you'll see our first polling question on slide 15. For this question, we'd like to know who was primarily responsible for quality improvement activities at your health center or free clinic. Now, we know that in many cases, all of the personnel listed on the slide will have responsibilities related to quality improvement, and your medical director may be ultimately responsible for quality improvement. However, we'd like to know on a day-to-day basis who coordinates quality improvement activities. And again, you'll see these answer options on slide 15. So, if you have a dedicated quality improvement coordinator or director at your health center, please press star 1. If your risk manager is responsible for performing most QI functions, please press star 2. If your medical director is responsible for performing most QI functions, please press star 3. And if some other staff member who we've not listed here is primarily responsible for QI functions at your health center, please press star 4. And again, you'll see those answer options on slide 15. While the results are coming in, I'll just mention that we will include the results of selected polling questions in an upcoming issue of the biweekly Risk and Safety e-News that comes out every other Friday, and the next issue is this Friday, April 20th. If you're not on the distribution list for that email and would like to be, please let us know. You'll see our contact information at the very end of the slides, and we'll read that out when we get there. But if you're not on board and would like to be on the distribution list, we're happy to get you on the list. Is the polling closed?
Yes, the polling has been closed.
Okay. Then I will turn it back over to Barb and slide 16.
Thank you, Paul. On slide 16, we're going to talk about the quality improvement plan that we just mentioned should be the foundation of your committee meeting minutes. A strong quality improvement plan has the potential to transform an organization, and it provides a roadmap for the entire organization in terms of providing high-quality care. All health center departments and services should be involved in quality improvement, particularly risk management, since, as we discussed earlier, quality improvement goes hand in hand with risk management. Some areas that may be addressed in the quality improvement plan are listed on the next 2 slides. Throughout this presentation, we'll refer to some sample plans and other resources that can help you in your efforts to develop a QI plan. However, you should develop your own plan based on the structure and needs of your health center. Slide 17 has additional areas that should be addressed in the QI plan, including data collection, monitoring progress and improvements, communicating results related to quality improvement to the board, and communicating results related to quality improvement to staff members, which we're going to discuss. It is important to remember that it's not sufficient to simply have a written plan available. You also have to make sure that the plan is adapted to your health center and that you're actually taking the steps to implement it. Slide 18. Methods for assessing quality or identifying areas for improvement include distributing patient satisfaction surveys to determine the patient's perspective on what areas might need improvement, looking at general health center data such as demographics of patients, frequency of missed appointments and patient flow issues, and distributing employee surveys or encouraging employees to report any quality-related issues or safety concerns. And then you can gather all of those reports and aggregate them and share them with the committee. Feedback should be provided to these employees to let them know what strategies were implemented to address the concerns. Event reports and medical record reviews can also be used to identify risk areas. Slide 18 shows just a few of the methods health centers can use to assess quality. Health centers should determine which methods work best for their particular facility and what aspect of care or service they choose to study or monitor. And whenever I was in a new organization and started a quality plan or updated a quality plan, look at where you already have data, where you already are collecting information, and start looking at that. Don't don't necessarily need to create new information. Take advantage of what's already in existence. Slide 19. Health centers can use identified quality and risk areas to help select performance improvement goals for the health center or organization, and then select measures to determine progress toward those goals, which we'll discuss in a few slides. Goals should be specific, measurable, actionable, realistic, and timely. These are known as SMART goals. The example listed on the slide, reduce wait times for patients to less than 15 minutes within 9 months, clearly states the goal and time frame for achieving that goal. Slide 20. For each area that you choose to improve, you'll want to organize a team of individuals who have knowledge and experience in that area and who will buy into the importance of improving performance. Teams will be different sizes depending on the scope of the effort, but each team should include a member of management or administration with the authority to implement a facility-wide change. It should also include providers with technical expertise in the area that's focused on, such as physicians, nurse practitioners, or nurses, and include individuals with day-to-day experience in the areas that are evaluated, such as medical assistants, administrative assistants, front office staff, back office staff. For example, in our example on the previous slide of setting a goal to reduce wait times for patients to less than 15 minutes within 9 months, a team may consist of the medical director, clinicians, nurses, and scheduling or registration staff. This will be specific depending on who within your health center handles that process. Slide 21. Selection of performance or quality measures is important for addressing an organization's overall performance. Evaluating executive performance and comparing performance to benchmarks. Measures should be selected by the health center's leadership, should be aligned with the health center's performance improvement goals, and should address areas such as health center performance, processes, outcomes, appropriateness of decisions, patient satisfaction, and staff satisfaction. The example on this slide is a measure that could be used to assess performance related to our example goal of reducing patient wait times to less than 15 minutes in 9 months. Other examples of measures may cover specific areas such as percentage of patients aged 50 to 75 with appropriate colorectal cancer screening, or the percentage of patients who have received recommended immunizations, and the number of patients asked about smoking and referred to smoking cessation resources. The governing board should review and approve quality measures and goals, and reports on progress toward goals should be provided to the board on a regular basis, which we'll discuss a little later in this presentation. Health centers and free clinics may want to begin with a small set of achievable performance measures and then add more over time as they meet performance improvement goals. Consider measures that are both important to your patient population and important for external requirements, such as pay for performance, accreditation, or certification. For example, if you've received National Committee for Quality Assurance, or NCQA, patient-centered medical home recognition, or you're considering seeking this recognition, you can refer to NCQA's published quality measures in order to improve your own practices in this area, as well as meet NCQA standards. An example of one of NCQA's measures is the percentage of uninsured patients who receive mammograms. For more information, you can go to NCQA's website at www.ncqa.org. Slide 22 shows some quality measure sources. Health centers and free clinics can use established measures from organizations such as HRSA, the National Quality Forum, and other organizations to set quality and performance goals for their organization and patient populations, and then assess their progress against these established goals. Links to quality measures and other information appear on the slide. You may be thinking, how do I get our leadership and our board to set quality goals. Well, all of that's part of developing your QI plan. So develop your QI plan and then bring it to your leadership and your board, and that's how the process gets completed. On slide 23, additional sources for quality measures also appear on slide 23. And now I'll turn the program back to Paul for our second polling question.
Thanks, Barb. And you'll see our second polling question on slide 24, and where we're going to ask about how you educate your staff on your health center's performance improvement goals. So if you do that education currently, educating your staff on the health center's performance improvement goals, please press star 1. If you don't currently educate your staff on the health center's performance improvement goals, but you do plan to develop that education, please press star 2. And finally, if you don't currently do that education and you have no plans to do so, please press star 3. Again, the answer options are on slide 24. If you do currently educate your staff about performance improvement goals, star 1. If you do not do such education but plan to, star 2. And if you have no plans to do such education, star 3. Again, I'll remind you that we'll include results from selected polling questions in an upcoming issue of our biweekly e-news. And again, the next issue of that is April 20th. And so you'll see some results in an upcoming issue. And if you don't currently get the e-news, please do let us know. We'll be happy to include you on the distribution list for the e-news. Is our polling closed then?
Polling is now closed.
Okay. And then I will turn the presentation back over to Barb and slide 25.
So on slide 25, now you've created a plan, and you've created a committee, and you've gotten sign-off by your leadership and your board, and now it's time to start collecting and analyzing data. One way to make sure quality data is continually being collected is to educate providers to document all necessary information relating to quality measures being used through checklists or standardized forms that providers complete during or after patient care activities, which can help prompt the provider to document necessary information and is helpful because it's part of their usual workflow. Electronic health records can also be used to capture this data. However, providers using electronic health records should still review each patient's entry to make sure any pre-populated data is accurate and makes sense for the patient. Data should be compiled and entered into an electronic database on a continuous basis, and the health center should designate a staff member, such as a quality improvement coordinator, to analyze and trend the data on a regular basis, such as monthly or quarterly. Quality data should be provided to the QI committee to evaluate during their meetings, and ultimately compiled in a report to present to the board. Health centers can use benchmarks to compare their data, such as data reported by other similar health centers or their own previous data in a historical trending, to compare their results to other centers or their own progress over time and identify areas that need improvement. Slide 26. Once you have the data and you analyze it, you now need to take action to improve. For areas identified that fall outside the norm, you'll want to look at what changes or corrective actions you can implement to address those problems. For example, you could look at providing skills training or other types of training, revising particular policies and procedures, or developing quality improvement initiatives that focus on a particular area. You should continue to collect and analyze data after implementing corrective actions to determine whether the changes that you've put into place are working and whether you need to reevaluate your efforts. On slide 27 is a graphic because of risk reduction strategies showing which kinds of activities have more impact or less impact. Some corrective actions are more effective than others and can be categorized into low, medium, or high impact. As you can see on this slide, low-impact strategies may include revising policies and procedures, conducting education and training, and documentation. Medium-impact strategies, you can minimize choices, standardize to the extent possible, or optimize redundancy. And optimizing redundancy means doing things twice when it is a good idea because you're going to double-check each other and make sure that you do it right. High-impact strategies may include communication, incorporating forcing functions or the way a person has to do it the right way, and incorporating fail-safe mechanisms. Now, we don't mean by showing this graphic that you should not do training and policies and documentation, but sometimes you need to do that along with the other higher impacts. Together, they're much more strong, and you're much more likely to see that improvements you put in place stay in place. Slide 28 shows a method of the quality improvement cycle called Plan, Do, Study, Act. This model is one method that is frequently used to test any changes or corrective actions and determine whether they work in your particular health center or free clinic. The steps in this model are that first you plan your test or observation of a particular change. If you're unsure of where to start, you may want to look at areas in your organization that are high risk or high volume or potentially problematic. Then you carry out your test, being sure to document all of your observations, including the problems encountered and unexpected results. Next, you analyze your data and results, comparing this data to your original predictions and determining lessons learned. Finally, refine your change based on the results of your study and plan any additional tests of your refinements. When testing changes, try to select manageable solutions that will have the most impact for your health center. Some questions you may want to ask after testing a change are, what did we expect to happen and what did happen? Were there any unexpected consequences? What were the best and worst things about this change? And what should we look at next? Keep in mind that you may discover during the testing phase that a particular change or corrective actions does not result in any improvements or is not feasible for your health center. These unsuccessful tests are part of the process and can help focus your efforts on other types of change that may work better. On slide 29, we're going to give you a scenario of Plan, Do, Study, Act model in action. As part of its quality improvement efforts, Clinic X looks at patient satisfaction surveys and determines that patients are consistently not being notified of normal test results. The clinic's policy is to notify patients of all test results, including normal results. But further investigation involving analysis of patients' medical records and discussions with staff members indicate that only about half of all normal results are communicated to patients, and a small percentage of abnormal results have fallen through the cracks. The plan is to organize a team to brainstorm ideas on how to improve test result communication. This team may consist of the medical director, primary care providers such as physicians or nurse practitioners or physician assistants who order diagnostic tests, laboratory staff, and information technology staff. You could also include medical assistants or other staff who are involved in the process. The team decides that the test result could be improved by modifying the health center's existing electronic health record to include prompts reminding the ordering provider to notify the patient of their test results, and also include a feature where the provider can download patient notification letters from the electronic health record and patient contact information. IT staff at the health center work with their EHR vendor over several months to make the modifications to the electronic health record and test the new system. And the new system is pilot tested over a 6-month period. Surveys sent to patients and staff indicate that patients are satisfied with test result notifications and that staff find the program beneficial and easy to use. Some refinements to the system were made based on staff and patient feedback. For the ACT phase of the model, all appropriate clinic staff members are educated on using the new EHR modifications, and the modifications are rolled out on a permanent basis. And for those of you who don't have an EHR, you can recognize through this scenario that you would do this with the paper version of the health record that you would be using. On slide 30, we talk about Six Sigma. Six Sigma was first adopted in the 1980s as a quality improvement plan in the telecommunications industry, and it's been adopted in the healthcare industry. Manufacturing companies applied the concept to define the amount of variation or deviation that is acceptable in a manufacturing process. The goal of Six Sigma is to eliminate the root causes of defects in those manufacturing processes. Healthcare organizations can use Six Sigma to set measurable targets for various healthcare processes, including projects to improve patient safety. The steps in the Six Sigma process are define, measure, analyze, improve, and control. You can see how they are similar to plan, do, study, act. You can choose a more in detail Six Sigma process, but we won't go into too much detail on the methodology. But you can refer to the reference slides at the end of your handouts for some resources available on this process. The Plan, Do, Study, Act, and Six Sigma models are just some examples of models you can use to test changes. There are other strategies available, and you should choose the one that works best for your health center or free clinic. Oftentimes, folks within your organization have used a process somewhere else, and they might prefer to use that process. Slide 13 talks about reporting to the board. The board and executive staff is ultimately responsible for the quality of care provided by your health center or organization and should be kept up to date on quality improvement data, initiatives, and results. The board should vote and take action on quality issues, provide guidance, oversight, and approval of activities, approve healthcare center policies, and approve and make decisions on credentialing and privileging of providers. The QI committee should prepare reports that will be provided to the board on a regular basis, such as quarterly, and include graphs, tables, or other visuals highlighting the health center's progress toward goals or results related to quality measures, areas identified for improvement, and corrective action plans or other initiatives. It's been my experience with boards that it's a good idea to include both the data and the graphics, but some people will be more visual and others will like the printed information more. Getting the board's buy-in for quality improvement is important because the board supports the CEO to supply the resources for quality improvement. If the board is involved and if they buy in, they can support the efficient use of your staff and your resources to get better outcomes. On slide 32, we talk about monitoring quality improvement. Developing a QI plan and program is not a one-time thing. Quality improvement activities need to be monitored on a regular basis with problems identified and strategies for improvement implemented. Getting staff input on improvement strategies and providing frequent feedback to staff on progress toward meeting goals keeps the staff in the loop and keeps everyone focused on improving quality. For example, you can post graphs showing improvement over time on a bulletin board in the health center, or include quality improvement data with visual graphs in regular newsletters to employees. You can provide incentives to employees, such as recognition programs or a gift card for meeting quality improvement goals for the quarter. These have been shown to help improve efforts. Make sure also that you provide both positive and problematic information, because to get buy-in from the staff, you want to celebrate their successes as well as encourage them to improve the areas that are opportunities for improvement. On slide 33, we see a case study of an outpatient pediatric oncology clinic's quality improvement efforts made in response to an adverse outcome experienced by one of the clinic's pediatric patients. After conducting a root cause analysis of the event, the clinic identified poor communication as a key contributing factor. The clinic also conducted patient and staff surveys as part of its quality improvement program, and those surveys also identified communication as an area needing improvement. A team comprising of an in-house consultant and nursing staff brainstormed ways to improve communication. The team then developed and implemented a quality improvement initiative to improve communication to prevent future adverse events from occurring. To improve communication, clinic staff have implemented daily care planning and safety rounds, which were meetings that were mandatory for nursing staff and strongly encouraged for other clinic staff, during which each patient was presented along with his or her diagnosis and plan of care in a process similar to the briefing sessions used in the inpatient setting before surgery and high-risk procedures. Staff coverage for caregivers with responsibilities outside the clinic that day, for example, to attend QI committee meetings, is also established during the round. The clinic studied the results of the initiative through the use of staff questionnaires and found that care rounds improved the staff's ability to associate patients with their attending providers, that staff and providers felt that the rounds were worth the time, and that communication among caregivers improved, and that patient safety improved. They also found some barriers which were identified in the staff surveys, including patient flow affected with the extra time used for the meetings, especially when staff members showed up late, and that input from staff members other than nursing, such as social workers and other clinicians, was needed. The clinic is working to make improvements to the process based on the identified barriers, such as by including other clinicians, social workers, and other staff members on the team. So this is an example of planning a quality improvement initiative, implementing the initiative, studying its effectiveness, and then making further improvements or refinements based on feedback from the study. On slide 34, you see the quality improvement resource page. This resource is available on the Clinical Risk Management Program website that can help you with the quality. One resource available on this resource is the quality improvement resource page. This resource page is a one-stop shop for all of the guidance articles, self-assessment questionnaires, archived audio conferences, and sample policies and tools available on the Clinical Risk Management Program website that relate to quality improvement, as well as other publicly available resources such as sample quality plans, toolkits, training programs, and online courses. I apologize that my mouth was not keeping up with my brain. In addition, on slide 35, look for the new quality improvement toolkit, which is to be posted on the Clinical Risk Management website in the coming months. This toolkit will include a sample quality improvement plan that you can download and adapt for your health center or free clinic. It will also include templates for quality improvement meeting minutes and agendas, worksheets and forms for testing changes, and more. We will continue to add to the toolkit and develop it as we identify other useful resources. In addition to these resources, HRSA is conducting a technical assistance call on their Uniform Data Systems measures today, April 18th at 3 o'clock Eastern Time. The call will also be archived on the HRSA website within the next week. Please also look for a Get Safe email on Monday, April 23rd, on supporting effective quality improvement activities. If you're not getting Get Safe series emails every month, we will be providing you with our contact information in a minute, and you can contact us and we'll get you on the distribution list. All Get Safe emails are also archived on the Clinical Risk Management Program website. And now I'm going to turn the program back to Paul for our final polling question.
Thanks, Barb. And you'll see our final question on slide 36. And very simply, we'd like to know how many folks are in the room today listening to today's presentation. You'll see the answer options again on slide 36. So if there is one person present, please press star 1. If there are 2 people, press star 2. 3 people, star 3, and so on. If there are 9 or more people, please press star 9. Again, you'll see those answer options on slide 36. And again, this is the last polling question for today's presentation. So once we wrap this up, I'll wrap up the presentation portion, and then we'll be ready to move into the questions and answers. So if you do have questions that you've been saving up during the course of the presentation, we'll have instructions in just a moment for getting in the queue to ask those. Polling wrapped up then?
Polling is closed.
Okay. Beginning on slide 37, you'll see references for the various slides that were presented as part of today's presentation. They actually go all the way on through slide 40. So you see a lot of great references, some of which Barb discussed during the course of the presentation. Others are simply in-text references from the slides. And we invite you to take a look at those. You'll see a lot of great links for some more information. On the very last slide, which is slide 41, you'll see our contact information. that I've referred to a couple times throughout the course of the presentation. If you need to get in touch with us for any reason, you'll see our email address and phone number on that last slide. And you can get us at clinical_RM_program@ecri.org. That's our email. Or you can give us a call at area code 610-825-6000, extension 5200. That's our Clinical Risk Management Program voicemail, and we monitor both the email and the voicemail continuously, and we will get back to you as quickly as we can with answers to questions, help getting on the website, whatever it might be. So at this point, we'd like to get ready and open the question and answer session.
Thank you. Again, as a reminder, to ask a question, please press *1, unmute your phone, and record your name clearly.
While questions are queuing up, again, I'll point you to this very last slide and say that in addition to, sort of programmatic questions, additional information about a QA program, again, this is also how you get in touch with us to get on our distribution lists or to have access to the clinical risk management website that HRSA provides.
We did get a question from Richard Dickey. Your line is open.
Oh, I was just asking how to print out the risk management quality improvement overlap function slide in a way that it was possible to read it.
Sure.
I tried to print out the one on the regular slides and it was too small to read.
Sure. At the very end of the slide set that you got today.
I'm on that. I'm on it, and it's labeled 1. But how do I print that out? Because when I clicked on it to print it out, it's printing me out the QA committee meeting minutes template 2, and a whole bunch of other stuff's coming.
Okay. I think the best way to handle that is if you can send us an email to that address on the last slide, then I'll have your address, and I'll send you just a single-page PDF of it.
Thank you.
Next question comes from Felicia Miller. Your line is open.
I'm sorry. I was just following up on as we're actually doing a QI plan and just implementing things that we find that have fallen short on the parameters that we set forth. How to actually implement, like, strategies, or what are you all suggesting as far as implementing those changes that we come up with?
So let me see if I understand your question correctly.
Okay.
So you have already identified some areas that need improvement.
Correct.
And you're asking for advice on how to implement actions to improve them.
Well, different ways of implementing. I mean, as far as, we do in-servicing with our staff and et cetera, but just any other ideas as far as different ways that we can do versus just in-servicing.
Well, I'm going to give you an answer, and I'm also going to turn it over to Chris. Usually, the different ways of doing things are dependent on the item.
Okay.
Sometimes you're going to look, if it's a process issue, you're going to look at a sort of a flow chart of the way the process goes and look to see if there are steps in the process that are making it more complicated than it needs to be.
Right.
And then sit down with the group of people who do the process and see how you can change that. Then you want to communicate that to all the people who are involved. Sometimes it's training and changes in policies and procedures, and other times it's implementing new forms. It's, like we said, on the medium and the high forcing functions. For instance, do you have an electronic medical record?
No, we're still paper.
Okay. So it gets a little hard to create forcing functions when you don't have electronic, but suppose you would look at, you want to make sure a certain form gets filled out every single time that record is done. So number one, you'd want to make packets of the paper record and make sure that form was included, so at least during that step of the process, the form was there and the user didn't need to run to find it.
Correct.
And then you'd want to put it in a place that's maybe not create a second form and put it as part of another checklist that always gets used and put that piece of information on there. That's another forcing function with paper forms. Chris, do you have any other ideas on the ways that people can implement actions?
Well, it's been my experience in the health centers and clinics that it's easiest if you're trying to do a measure. For example, let's pretend that you have an access problem on the telephones in your health center. What I've found is to break it up into bite-sized pieces. In other words, identify the different job function or the role of the person and tell them what their expectation is to improve that measure. In other words, it sometimes can be very difficult for people to kind of look at a checklist that might have what the physicians are supposed to do, what your receptionist is supposed to do. It might be prudent if you're doing your in-services to say to your front desk reception, your job is to make sure that the calls are answered on the third ring. Something very, very easy and manageable. You might actually put that in your QI goal, that your frontline staff will answer the phone on the third ring. Your MD staff or your provider staff will answer those phone calls within 4 hours. Your IT folks will give you a report on the percentage of time that the line is busy. So you could take all of those little pieces of information and put it in your plan to be able to say, okay, where are our problems? So my advice, at least at the health center level, is to break it into bite-sized pieces for the folks that you're trying to teach.
Okay. And Chris, you made me think of something else as you were saying that. When you break it into bite-sized pieces, go to the staff, say, I see this problem, and do you have any ideas on how we can improve this? Because sometimes they'll have ideas that you may not think of when you're managing and not dealing with it day in, day out. So they're a fount of information, and you don't have to work so hard because they'll come up with the ideas. And when they come up with the ideas, they're more invested in the improvement.
Okay, thank you.
Next question comes from Ken House. Your line is open.
Oh, hi there. We have 3 sites right now, and we're going to expand in the future to additional sites. And we're kind of struggling to figure out how to structure our quality committees to make the best use of everybody's time, because, as you know, these committees need to address a wide range of both clinical topics and operational topics. And so we have I'm wondering if you could speak to, structures that you've seen effective in the community health center world for having site-specific committees and who should be on those. And then do you have an overall sort of oversight committee? And then also how those quality committees at the sites might relate to the safety committees that deal mostly with OSHA things. Does that make
Yes. I haven't done the health centers as much, but I did a lot of managed care physician office practices. And it depends on how you have your multiple locations set up. If the staff is pretty much stays at the one center, especially the physician providers, if they stay at each center, you may want to have a quality subcommittee at each one with an oversight committee. If they are moving through it and you're using the same processes no matter which location, you can probably have one committee. And now I'm going to ask Chris to who's out there more often to share what she may have seen.
I kind of concur with what Barbara's saying, and what I would really give you the thought about is you've got 3 health center locations, and let's say you are trying to meet meaningful use to get your HIT incentives. Let's say you're also trying to look at NCQA, patient-centered medical home recognition. Let's also say that you have to have a QI plan for your board. All 3 of those things, in many cases, there are redundancies and duplicities that can be used for multiple different areas. So what you would want to do, and the NCQA patient-centered medical home, if you aren't familiar with it, has certain goals that they consider center-specific. In other words, if you have 3 health centers under your sort of plan name or your practice name, you can answer certain standards in a specific standardized way. I would encourage you to have one committee that sort of is able to parcel out, and then you'll be able to identify those particular items that need to be done at the site level. There are certain goals and measures that have to be done at your site level, but there are job descriptions and things that you could do for your QI plan that could be done at once and just rolled out to your centers.
And I'd like to add to what Chris said. She makes a really good point. A lot of QI committees and QI programs get bogged down because there are multiple separate initiatives going on. And it's very important to have someone who can coordinate that, either the QI coordinator or someone else, to take one activity that meets the goals of various initiatives you're trying to handle. Now, the other thing that you asked, I believe, was how do you relate the safety committee and OSHA pieces to your QI committee? And when you're a larger organization with multiple safety issues, you probably want to have a separate safety committee to deal with those things, and then have that safety committee be part of the QI, the chair of that safety committee be part of the QI committee and report a summary of what's going on with safety. In smaller organizations, safety can be part of the quality committee. It all can be rolled up into one.
Okay, thank you very much. That's helpful.
Next question comes from Mary Beth Cox. Your line is open.
Hi. You may have answered this in part on the last response, but I was interested in any insights you would have in terms of thinking patient-centered medical home and how you would integrate that into your QI, or what your recommendations would be around that.
Well, a patient-centered medical home, many of the requirements from if you're going for certification by NCQA are a quality program. So you would probably want to look at that and determine which of those, if you already have a quality program, you'd want to determine which things you're already doing. If you do not already have a quality program, you want to look at those patient-centered medical home criteria and make sure that you have them, and then add to that for your overall quality plan things that are important to you that don't seem to be addressed by them. But you don't want to do two separate efforts. You want to coordinate the two together. Chris?
Yes, and just to give you kind of a real-life example, as you all know, if you're going for NCQA, Patient-Centered Medical Home 2011 recognition, there are 6 standards, 27 elements, and a total of 149 factors. That can be overwhelming. As Barb pointed out, and one of the really good strategies is to basically look at what you're doing now and dovetail it into what NCQA is looking for you to supply to them. And then you might have to tweak, and let me give you an example. If you have, for example, an answering service for access to your center after hours, what I might encourage you to do is, are the physicians responsive to a patient who calls your health center at 8 o'clock at night? And, for example, that can be a very easy and very straightforward way of doing it. Your QI committee may have a plan that says, let's look at after-hours care and make sure we have policies that address that. Back to what Barb said earlier in the presentation, we need to look at behaviors that can measure that. So what I might encourage you to do to answer your question is to look at the NCQA standards, look at your QI plan, and make sure that there aren't redundancies. Make sure that you can double dip. You can be doing your QI/QA plan and at the same time satisfying what you need to do for your patient-centered medical home recognition.
Okay, thank you. That was helpful. Thank you.
Next question comes from Felicia Brown. Your line is open.
Just a quick question. The Get Safe information, are you going to provide us with an email to sign up for that, or?
Sure. If you look at the, I guess it's slide number 41, it's the very last slide in the deck. If you're not already getting those emails, send us an email at clinical_RM_program@ecri.org, And then obviously just let us know that that's what you're writing for, to sign up for those emails, and we'll get you on the distribution list.
Sounds great. Thank you.
Thank you.
And last question comes from Vanessa Whittaker. Your line is open.
Yes. My question is really concerning the QI information being reported to the Board of Directors. I wanted to know if there's when you report that information to the board, should it be detailed or should you give them a general summary of activities? And the reason that I'm asking that specifically has to do with things that, with adverse or sentimental events that could potentially be discoverable in board minutes, and you don't want that somehow to come back on you later on?
Okay, well, you have two questions there. How should you report the information to the board, and how do you report sensitive information? So I'm going to first talk about how do you report information to the board. It's been my experience that there are several kinds of board members. Some like the detail, and some just want to see the bottom line. So in the reports, if you have a process, a lot of boards, there's a process where they get a board book and they get it ahead of time. Others, it doesn't happen until they're there. And others now are starting to use the iPad and they get it on their iPad. Some people use dashboards or graphs to just summarize things, and then they bring along the detailed information, or they provide some of the detailed information. So that's what I was saying when I said do a graph plus a table of the data, because you'll have some people who like to sit there and add up the numbers and double check your work, while others just look at the graph and show the program. So bottom line is, I would do a little bit of both, but then you have to judge when are you starting to overwhelm them. If the detail is such, and I've been in organizations where their board meetings were 4 hours long because the quality committee sent every tiny detail that went to the quality committee and then went over it yet again with the board. That is going to make it very bogged down, and then it's not going to be productive. They really need to see the high level. So you have to go into that board meeting deciding what decisions do I want from these board members, which things do I want them to approve, which things do I not want them to approve, and which things are just informational. And sometimes when you do the agenda for that, it's good to say that. Approval needed, informational only. Now, regarding the other piece of your question, you have to look at your state peer-reviewed legal protections. If you're, I don't think many of you are, but or the Patient Safety Quality Improvement Act protections, if you're intending to participate in that. But you have to look at that along with your legal counsel, because only your legal counsel knows the way the courts are deciding things in your area and the way that has worked for them in your area. So you really should check with your attorney. Chris, do you want to add anything on what you've seen to work really well presenting to the boards?
Not really. I do think that it's very important to check with your, if you have the counsel. The only thing that has been my experience is that many health centers and organizations will always put a footer at the bottom of any minutes that protect and cut that information from being disseminated.
Okay. All right. So I think that was our last question. If there's anybody who either didn't make it into the queue or we do need to cut it off because of time. So if there's anybody who did just not make it in and you do have a question you could ask, I think we had some great questions in follow-up to the presentation. So if you've got more like that, we'd love to help you out. Please do see that last slide for our email and phone number. We are absolutely available to answer these kinds of questions at any time. We'll get them to Barb and to Chris and to other folks here at ECRI who can provide some insight, and we'll be more than happy to do that. And again, you can also direct questions about access and email distribution lists to the same email and phone number, and we'll take care of everything right through there. I want to thank everyone for being on the line with us today. Thank you, Barb and Chris, for being on the line and presenting and answering questions. And I do hope that everyone has a great day.
That concludes today's call. Thank you for participating. You may disconnect at this time.